Hi, everybody. My name is Jenna Buckner. I am a clinical program manager from Blue Cross Blue Shield of Minnesota. And today we've set up a webinar that is going to help discuss diabetes and skincare. So first, I just want to introduce why we're all here today, and that is for what we call PIP. And a PIP is a performance improvement project. We collaborate as managed care organizations with most of the plans within the state to improve, in this case, diabetes care for our Medicare, Medicaid population. So we've been working on this PIP for since 2021, and it's a 3-year program that will run to 2023. So as part of that program, we work together to offer webinars and other interventions to help our care coordinators, case managers, and of course our members, in educating them in how they can support our members. So this is one of the great things that we've all come together to do today. So thank you to the other managed care organizations who we work with, which is, of course, Blue Cross, as I mentioned, which is us, Health Partners, Hennepin Health, Medica, South Country, UCare, and I apologize if I missed any as well, but we all work together to put these on for you. So we are very excited to present this webinar. And if you want to go just to the next screen here. So again, this is the diabetes and skincare webinar. I have my my partner here. Her name is Becca Treble. So she is going to be our presenter, and she is a specialist complex care manager in Blue Cross, and she is an RN, MSN, APRN, and CNP. She has her background is mainly in community-based care management, including providing care to all ages for complex pediatrics to geriatrics, and she has training in high fidelity situations. So we're very excited to have her and present on diabetes and skincare. And just as kind of a last housekeeping topic, so we will be doing a Q&A at the very end. Feel free to put questions that you have in the chat as they come up, though, and then we'll address them at the end. Again, at the end, when we do our Q&A, if you have a question that was not in the chat, you can just do the raise hand button, and we will unmute you at the end. So again, excited, and thank you, Becca, for taking your time to set this webinar up. We really appreciate it, and I'm excited to hear more. So I will send it over to Becca to take it away.
All right, thank you, Jenna. So yeah, I am Becca Treble. I'm excited to be here today. My understanding is that those of you attending today, there might be those of you in different roles, different scopes of practice. So some of the content today, I apologize, might be review for a few or more of a few of you here, but I do hope that there's some information in here that everyone can find things to add to their knowledge or to their practice, which will benefit your patients, and that's ultimately what it's all about. So firstly, we're going to be talking about diabetic skincare and neuropathy concerns. So I did just want to kind of take a step back and just go over a little bit of review again for all of us, just to kind of understand exactly why and how there are skincare and neuropathy concerns for diabetic patients. So thinking in terms of diabetic patients, high blood glucose levels in diabetics can over time damage those blood vessels and nerve endings. The combination of the damaged vessels and continued elevated blood glucose in the bloodstream can reduce circulation, and continuing to have those increased blood sugars levels, that also creates prime conditions for bacterial or fungal growth, while also decreasing blood supply for promoting the healthy tissue and healing. And then the other factor that we're going to talk a little bit about too, the comorbid conditions. So, those other disease processes that contribute and compound complications, and particularly the ones that we're going to talk about are the ones that impact blood vessels and circulation. excuse me, this damage to the blood vessels and the nerves, it leads to end organ damage. I think most of us have probably heard that term. By definition, end organ damage is damage occurring in major organs that are fed by the circulatory system due to the disease process, such as diabetes, as we're discussing today, as well as hypertension, hyperlipidemia, heart failure, which is why we're also going to be talking about those comorbids today. So when considering the care of a diabetic, and I know we're here to talk about skincare, but again, we have to consider the first step of caring for the skin. And this first step is going to be the goal of preventing or slowing the progression of the disease process that's going to impact their skin. So preventing those complications that come with high blood glucose levels. And we do that by ensuring the patient, the person, has a good diabetic management plan and one that they can and are able to be compliant with. Because we all know you can have a plan, but not every single patient can necessarily or will necessarily follow it. So good management of their diabetes, it starts with monitoring their blood sugars and their A1C. So consider, do they monitor their blood sugars? Do they monitor them at the frequency that their provider has requested or directed? Do they know their A1C? Do they know what their goal A1C is? Those numbers are important for a diabetic patient to know and to understand. And with our patients, one of the things that we can do are make sure that we're asking those open-ended questions to patients. Just, you know, as far as asking, do you know what your A1C is? Do you know your goal A1C? And why is it important that you're trying to lower your goal A1C? And letting them explain those answers to you is going to give you a really good idea as far as what their knowledge level, their education level, and their understanding of their disease process. And that's going to help you identify where there might be gaps that you can kind of help with. So if do they have monitoring equipment, or is this an area that we can assist in getting them working monitors, education to use the monitors and the testing supplies? And the other factor too we have to consider is, are they physically able to do the monitoring? Some people struggle with doing their blood sugar monitoring. And so those again are going to be gaps that we might be able to find that we can help address so that they can manage their blood sugars. When we're thinking in terms of the medication and treatment compliance, do they follow up with providers on the schedule that they've been directed? Do they need a provider, either a primary care provider or an endocrinologist? If they don't have one, assist in locating one. If theirs is retiring or retiring soon, which I don't know about everyone here, but I've had a lot of patients who've had their providers retiring within the last couple of years. So if that's the case, assist them in finding and making sure that they're getting established with a new PCP or with a new endocrinologist, because that gap in not being established with a provider can actually have a serious impact on them following up and following their treatment plan. Medications. Do they pick up their medications, and if not, why? This is a big one. You know, in terms of kind of determining if they're taking their meds, if they're taking their meds as they're prescribed, and asking the questions, you know, what's getting in the way of you taking your meds, picking them up. So if it's cost related, consider prescription assistance programs, insurance for in-network pharmacy options, local pharmacies versus mail order. There can be cost differences there. 30-day fills versus 90-day. There's also cost differences typically there. And you can look at alternate pharmacies. Sometimes just shopping around, even at the local pharmacies, different pharmacies have different price points for the same medication. So sometimes just switching to the pharmacy down the street can actually save them money and help with compliance if cost is a factor. Do they take the medications as prescribed? Are they missing doses? Consider education on tips and tricks on how to not forget meds, how to not miss medication times, and consider those things like MediSets. So nutrition, diet, and activity considerations, these are so important for helping to control blood sugars, and utilizing diet and activity to help those to control blood sugars can help in reducing the needs for medications for some folks. So are they knowledgeable of a diabetic diet? Consider referral to a diabetic educator or dietitian if needed. Are they continuing to be physically active? Up here in the Midwest, I have a lot of patients who maybe they're pretty good about it in the summertime, and then it gets to be winter and everyone sits in their houses. I think a lot of us do. So try and help them find ways to be continuously physically active to keep getting that activity and to help control their blood sugars. So think in terms of local gyms or community ed offerings. Even in smaller rural communities, there's oftentimes different community ed programs for activity or exercise. Senior centers are really good places to look for some folks as well, the Silver Sneakers programs. And the other thing I think a lot of us might be aware of, or maybe not, some school districts actually have open gym times at the whether it be the elementary or the high schools, for community members to come in and use the walking track or use the gym. So just kind of think out of the box as far as ways to get them out of the house active, particularly in the wintertime. And the other part of good management is managing those comorbid conditions. So are they following the treatment plan for those conditions? Are they established with a provider? Are they doing their provider follow-ups? Are they taking their medications? The same thing applies for those. So if you have a patient or a client with a new diagnosis of diabetes, or maybe changes to their diabetic management plan, we want to make sure that we're setting them up for success right away, so that they can get all the education and just kind of get established on a really good treatment plan, get compliant with the treatment plan so that they can prevent complications down the road. So kind of the same deal that we talked about, making sure that they have provider visits scheduled, the pre-CP or their endocrinologist, depending on who's going to be managing. Make sure they have an initial visit, make sure they have their follow-up visits, make sure they have their treatment plan, and make sure that they have a management plan for those comorbid conditions as well. So we don't want to get so focused on just the diabetic plan. That's kind of the point, with making sure that we're considering those comorbids. We don't kind of forget those. Medications, ensure they're able to pick them up, that they do actually pick them up and that they're taking them. That's one thing I hear from providers, prescribing providers. They'll prescribe a medication and then they see their patients, 3 months or 6 months later, and the person never picked it up. Or they started it and they decided to stop it for some reason. So any follow-ups that we can do to kind of support and make sure that they're following treatment plans is really beneficial. New diagnosis, a great thing to do is get them connected with a diabetic educator right out of the gate. That person can help them with nutrition education, start the conversation about activity levels, help them with their blood sugar monitoring education. They can help in teaching how to use their equipment. And then they can also help with teaching administration of insulin if that is something that's prescribed to the person. And then also think in terms of the durable medical equipment. So make sure that they get their monitors, that they have access to getting them, that they pick them up, and that, again, that they know how to use them. Huge important consideration when we're talking about getting them set up for success here. So whether it's a new diagnosis for them at the clinic or they're getting discharged from the hospital, and even if they're just leaving the clinic or leaving the hospital with a change to their treatment plan, consider how we can best support that person for optimal understanding of their disease and treatment. Yes, there's discharge instructions and after visit summaries. A lot of people don't go back to those, and a lot of times they're just kind of left by the wayside, so to speak. So typically, they might, especially after a discharge from the hospital, they will have their follow-up with their PCP scheduled a week later. But we want to keep in mind, especially for the patients or clients that this is a new diagnosis for, and even those where there's changes, just so that we can make sure that they're fully set up for success. That education piece typically is going to take repeating. They're going to have to hear it a couple different times for it to be fully absorbed, and a few check-ins and a few touch points from us, and as part of their healthcare team, can make a big difference as far as their compliance with their treatment plan and managing their health. So some things that we can do regarding that is consider spacing of appointments. So can we stagger the PCP visit and the diabetic educator, maybe 2 weeks later? I think sometimes what we do, if possible, when we're scheduling appointments is we want to think about efficiency for the patient. And if you can get them in to see the, the provider and then the diabetic educator on the same day, we're thinking that saves them time. It saves them a trip to the clinic. And in some cases, we do have to consider that. But if it's possible to stagger them, you're going to increase those touch points and the repeating of the education, and make sure that if they have questions between the PCP visit, they have that diabetic educator touch point coming up to kind of help clarify or help support them at that point. So that's just one consideration that we can certainly do. Another thing to consider, if you're in a position, can we make sure that they have a follow-up call 1 to 2 weeks after a treatment plan change, or 1 to 2 weeks, after they get prescribed a new medication or a new dose, just to make sure, how's it going? Did you pick it up? Any side effects, any questions, so that we can know sooner if there's any barriers and we can help support and address those. So now that we've kind of considered the overall treatment plan, we can start talking a little bit about the skin. Important for diabetics, keep skin clean and dry, but not overly dry. For diabetics, it's going to be all about balancing things. So a few things that we can certainly be directing and educating them on: bathe with warm, not hot water, and use mild soap. Hot water and harsh soap can dry out your skin, which leads to easier breakdown. So if they're having bathing difficulties, some of this education might be given to family or caregivers, or we might also be needing to get them set up with bathing assistance if it's paid assistance, home care, that type of thing. Those are factors we might have to be discussing as well. So we want to prevent dry skin, so moisturize with lotion is needed. A good practice is to gently pat skin dry, apply the lotion before being completely dry, as this helps seal in moisture. Important not to use lotion in between toes or in skin folds. So we want to make sure that we are thoroughly drying skin between the toes and the skin folds. Moisture can collect in those areas, and that's going to more readily promote bacterial and fungal growth, as well as lead to breakdown. We can also suggest, especially during the dry months up here in the Midwest, consider bathing less if they're able during the dry months, again, to kind of prevent that dry skin. And then treat small cuts right away. Wash it with mild soap and water and cover with sterile gauze. Only use antibiotic creams if the provider directs. The reason for that is antibiotic creams can actually be kind of drying to the tissue. And so sometimes they can actually hinder the healing process, particularly in diabetic people, because they already are going to typically have some decreased circulation issues, which are going to cause some circulation issues with getting healthy tissue. So the key word here is small cuts. Certainly, wash them, cover them if they're small cuts. Anything more than a basic cut that's easily covered with a Band-Aid, the patient should have a provider evaluate it. Always steer to the provider for any major cuts, burns, or any concerns for infection. So protect and check the feet. I think all of us are aware there's a lot of foot care concerns for diabetics. Direct them to wear shoes and cover their feet at all times. I'm going to probably repeat this a few times during the rest of this presentation. Should be wearing shoes at all times, indoors and outdoors. Make sure they have proper fit of footwear. Consider flat, wide, supportive footwear. We want the shoes to be protective, as well as not for the shoe itself to cause rub areas, calluses, sores, that type of thing. Consider diabetic shoes. We can steer them to the provider, podiatry, if needed, and they can certainly help with footwear determinations as well. Wear clean, dry socks. That can reduce moisture and bacteria contact. Examine the feet daily for red areas, cuts, sores, blisters, calluses. This is so important for diabetics to get in the habit of examining their feet every day. Diabetics may not feel problem areas due to the neuropathy, which we'll get to later. They may have a decreased sensation for pain, temperature, touch, and this is going to add to their vulnerabilities for these injuries. And so they might not feel that they have an injury, and if they're not examining their feet, they're not going to see it either. So things such as an ingrown toenail, callus, skin ulcer can go unnoticed for a really lengthy period of time in some cases, which is going to increase the risk for those infections and complications. Also important, stress as they're examining their feet daily, that they inspect all surfaces of their feet, which includes in between the toes and on the plantar surface. If they have difficulty seeing the bottom of their feet, you can certainly offer the suggestion to use a mirror to visualize the bottoms of their feet if needed. Also consider their vision needs. We might have patients that have cataracts, glaucoma, macular degeneration, retinopathy, other vision concerns that are going to impact their ability to monitor and examine their own feet. If that's the case, address what you can with their vision, but also kind of help them find alternate methods and solutions as far as being able to keep watch over those feet. Trim the nails regularly. Use caution when trimming nails. Get help if they're not able to do it independently. So a family member, foot care clinics, local in-home foot care services. Sometimes some senior centers I've seen occasionally have a nurse come in and do foot care. They can register for time slots. And some provider offices I've seen in some cases have done them as well. So just kind of check around and see what's available. One of the things that we can certainly make sure that we're teaching our diabetic patients is to remove their shoes for the provider to check their feet at every clinic appointment. The patient should learn to get in the habit of removing their socks and shoes at the start of every appointment. It's going to prompt the provider to evaluate their feet and make sure it's not forgotten. If the patient waits till the provider's in the room, and then waits for the provider to ask them to remove their shoes and feet, sometimes they're there for a different reason that's not related to their diabetes and not related to their feet. And so it doesn't actually happen. But if your patients just learn when you go to the doctor and you're in the room, take your socks and shoes off and have your bare feet open there from when the provider walks in, it's going to prompt the provider to take a look at them. And so why do we talk about wearing shoes at all times? We can never predict when and where and what may cause a potential injury or an insult to our feet. One small Lego, I think we've all stepped on something at one point or another. It can create a cut. One small item dropped can create a wound. A toe stubbed, it can damage or remove a toenail. The other things to kind of think about too are if you have pets. I don't know how many of you have dogs. I have dogs that have stepped on my feet and left cuts and wounds on my feet. Or if you've got small children or grandchildren, they're not always the most conscious about whose feet they're walking on either. And that can cause an issue if you don't have shoes on. So I have seen situations where all of the above have led to infections, wound care needs that can last for a year or much longer in some cases. In one particular case, I had a diabetic patient who was wearing socks, no shoes, was getting an item out of her freezer. A can of frozen juice mix fell out and landed right on the top of her toes and foot, which left a bruise, turned into a wound. Extensive wound care, I want to say for about 2.5 years. And eventually, it was about 3 years later, it led to an above the knee amputation. So wear shoes at all times. It's not worth it for a diabetic not to wear shoes. So some other things related to the skin we want to make sure that we consider is any incontinence considerations. So urine and fecal matter can increase the risk for skin breakdown and infection. We want to make sure that we're promoting cleansing and drying of skin areas, monitoring for signs of breakdown. Consider how you can ensure the patient has what they need for bathing. Make sure they have bathing assistance if that's something that they need. Do they need things like a bath chair, a walk-in shower, a handheld shower, family or paid assistance again to help them? Just making sure that they have the things that they need to get fully clean and dry to prevent breakdown and having that incontinence kind of contribute to that. Another important thing to keep in mind, there are some medications like the SGLT2 inhibitors, we're starting to see those prescribed quite a bit more. So the Farxigas, the Jardiance, these medications, they increase the sugar in the urine. They work to lower blood sugar by blocking the protein SGLT2 in the kidney from reabsorbing that excess sugar in the blood, which is great because it decreases blood sugars, but it that excess glucose that's excreted in the urine can cause risk for UTIs, yeast infections, and it can promote accelerated, and in some cases, rapid acceleration to skin breakdown if it's against the skin. So especially those patients that are incontinence or have incontinence concerns. So this is a huge thing to keep in mind, and speak up for your patients or your clients. If they are prescribed this medication and have incontinence, there should be a conversation occurring if this is in fact the best medication for them. Or if they're on this medication and they develop incontinence, it should trigger us to, encourage and advocate for them for some considerations if they might need to consider a change to a different medication. So if there is a wound or an open area, promptly, and I can't stress that enough, get them directed to a provider for a care plan. Their care plan might include antibiotics, wound care, dressing changes, some nutrition changes. Diabetics are at risk for increased risk of infection, which we've kind of touched on. Slower healing, that decreased blood circulation to support that healthy tissue growth and healing. And they can develop severe complications such as sepsis or gangrene, and that can lead to subsequent amputation, like we kind of mentioned with that one patient earlier. So again, if there is an open wound, open area, make sure you're stressing not to leave it, because these can get very complicated very fast. So the next slide is going to be a couple pictures of different diabetic wounds. In this case, the above photos show diabetic ulcers and the effects of decreased circulation to the toes causing necrosis of the tissue. The patient impacted in both of these photos above could not feel these wounds. So that's why I can't stress enough, they're examining their feet, all surfaces of their feet, and they are removing their shoes when they see the provider. Because again, I've seen a lot of patients who start to have wounds, and even wounds this bad, before a provider even lays eyes on them. This patient had a longstanding plantar ulcer that became complicated osteomyelitis. The X-ray shows the fourth metatarsal had actually become separated from the rest of the metatarsal bone. So again, proper footwear, proper fit doesn't cause issues, and examine those feet, including those plantar surfaces. Suggest that mirror again, make sure someone is checking their feet, and make sure that we're reinforcing with our diabetic patients, their caregivers, their families, that just because the patient doesn't have pain, it doesn't mean that it's not a problem. Can't stress that enough. I think a lot of people don't worry about it until it starts to hurt, but just because it's not painful doesn't mean it's not a problem, and that needs to be understood with these patients. This is something I think most of us, if we've had contact with diabetic patients, we've likely seen. On the left, you see diabetic ulceration of the skin, due to that, the high blood glucose over time is going to impact that circulation. On the right, we see worsening and opening of those diabetic ulcers. These can be incredibly difficult to close once they're open. It can take months, if not years, if ever, for some patients once they have these wounds open. If you see this on a patient, they should be referred to a provider, and they will need to be connected to a wound care provider, wound care clinic, wound care nurse for ongoing care, just to best manage these and prevent them from getting enormously worse. So this highlights the importance of prevention of skin issues. Manage the diabetes through best practice that we talked about, with their making sure they have the right meds, they're compliant with their plan, they understand their plan, and assist them in kind of closing any gaps that you identify. This also highlights the importance of proper skin care. Don't over dry the skin, apply those lotions like we talked about. And any areas of concern on skin should get a prompt steerage to a provider for an evaluation so they can have a treatment plan and start addressing it right away. Wounds should be managed, like I said, by a provider, wound care clinic, wound care nurse. Treatments often are going to be include keeping the wound clean, properly dressed. There's going to be a number of dressing options, and a provider that's familiar with treating wounds should be the person that's directing which products to use, because there can be a variety of with the different variety of different options for treating wounds. If you use the wrong one, you can potentially make the wound worse. So that's why it's really important to get them connected with someone familiar with treating them. But sometimes it can range from just Curlex, which is just the fast wicking, airy, and absorbent Curlex that most of us have seen. Tegaderm, the clear, thin covering that's waterproof, provides a barrier. To compression systems with different layers, different foams, and then there's also a C-sorb alginate, which is actually a dressing that ends up getting used for deep tissue wounds to help kind of absorb and clean out the exudate. Another treatment component is typically going to be antibiotics. It's going to be to treat any infection that might be present or to prevent any infection. Surgical debridement is something that we see, especially if it's kind of a deeper tissue wound, if it's an infected wound, or if there's connective tissue involved. Essentially with the debridement, if the wound edges are necrotic, they're not going to heal. So the surgical debridement will actually remove the dead and non-healing tissue in order to promote that healthy tissue, kind of expose it so that it can actually kind of approximate edges and start to close and heal the wound. Referral to, again, the PCP, wound care specialist. And I think we're all kind of aware that at some point, if the wound is so bad, we do see limb amputations at different levels for different patients as well. So talking a little bit about kind of wanting to go into some of these comorbids that we need to be aware of. This is critical to optimal diabetic management. So again, don't just focus on having a compliant diabetic plan. We need to make sure we're managing these other conditions as well. Hypertension, the damage done to the arteries over time, done to the kidneys, all of that is going to compound with those high blood glucose levels from being diabetic. So they should be monitoring their blood pressures. If these are increasing, that's an indication they're not well controlled. This should be steerage back to the provider to address that, make some medication changes. Compliance with medications, same that we've talked about. Are they filling them, or are they picking them up? Are they taking them? Hyperlipidemia, the plaque that develops, it narrows the arteries, impacts circulation, compounds the complications. Hyperlipidemia is also a factor that increases a diabetic person's risk for developing neuropathy, which we're going to cover shortly. So kind of dual purpose for good management of hyperlipidemia in a diabetic right there. So being diabetic increases a person's risk for developing heart failure. You see it very commonly that they have both diagnoses. So stress, good heart failure management, compliance with their treatment plan, steer them to the provider for any concerns. A very basic number a heart failure patient can monitor is going to be their weight. You know, changes or worsening with their heart failure over time are almost always going to be demonstrated by an increase in their weight before the person even starts to develop any other symptoms. So a common rule to consider and to teach to your patients, make sure that they understand their specific provider might have different parameters, but a common one is if the person has 2 to 3 pounds weight gain in 1 to 3 days or 5 to 7 pounds in a week, they should be contacting their provider, even just to say, hey, doc, I've gained 5 pounds in the last 4 days. Even just to say that, it's going to flag to their provider that that's a concern, and they will very likely make some medication adjustments to address that before that condition actually worsens. So in order for this to be successful, the person has to be monitoring and recording their weights daily. So that's something that we can teach them. Check your weight every morning or every evening, same time every day. Write it down and give them these parameters at the very least. That's a very basic tool that most people can follow. Peripheral artery disease, hypertension, hyperlipidemia, and diabetes all individually increase the risk for PAD. So both heart failure and PAD can cause lower extremity edema, sometimes extensive edema. Over time, compression stockings are usually going to be very beneficial and are going to be directed and ordered for these patients to manage that edema, but they can contribute to or create skin condition or skin issues. So educate on the importance of proper fit and proper stocking. So the size, the height, the level of compression. Stockings that don't fit well or properly are going to do the opposite of intended. They can create strangulation of tissue. They can create pressure areas that can turn into pressure wounds. Suggest the patients discuss the compression stockings with their providers, and also suggest that these patients be fitted to ensure that they get the right size, both in the fit and the level of compressions. These are not patients that we want to just say, hey, go to your local Walgreens and pick up a pair of stockings. We want to make sure that they're getting the right stockings, the right fit, so as not to cause additional complications because of the stockings. This slide I just put in here just so we can kind of see, if you have multiple different conditions, they all kind of work together to cause all these complications, and ultimately can kind of have a negative outcome if they're not well controlled and not addressed. So moving on to neuropathy. Neuropathy affects approximately 50% of patients with diabetes. Sometimes this is going to be the first reported sign. It's going to be the reason that they go into their provider and say, hey, doc, I can't feel my toes, or I've started to have falls or whatnot. And that's when they get diagnosed. So high blood sugars, just like with circulation over time, they're going to cause damage to nerves. The risk factors that make the nerve damage more likely are going to be poor controlled blood sugars. The longer a person is diabetic, increases those neuropathy risks, especially if they continue to have uncontrolled high blood sugars. Diabetes can cause damage to kidneys. Kidney damage actually then will send toxins into the blood, which can lead to nerve damage all on its own. Additionally, obesity and those high triglycerides and cholesterol levels are associated with increasing a diabetic's risk for developing neuropathy. So again, think back to those comorbids. Good control of hyperlipidemia and supporting weight loss for a diabetic is also great benefit. So the American Diabetes Association recommendation for diabetic neuropathy screening, it should begin immediately with diagnosis of type 2 and 5 years after diagnosis of type 1. After that, the screening should be yearly. So again, make sure these people are getting in at the very least for their annual exam. These are not people that we want to just, let them keep pushing off their annual well checks. So the difference in the timing of the initial screenings between type 1 and type 2 is actually based on studies that found that enhanced glucose control. So if you have well-managed, well-controlled blood sugars in a type 1 diabetic, that will reduce their probability of developing diabetic neuropathy by 78%, which is actually pretty amazing. Contrasting a well-managed type 2 diabetic with well-managed blood sugars, it only reduces their risk of developing neuropathy by 9%. The fact that there's such a difference between type 2 diabetics and type 1 as far as their probability here is associated with oftentimes type 2 diabetics have had asymptomatic hyperglycemia for many years prior to their diagnosis. And so oftentimes the disease process has actually progressed much farther before they actually get diagnosed. So most commonly, the screening is going to include checking muscle strength and reflexes, sensitivity to position, vibration, temperature, and touch. Some additional parts of the screening that might be included depending on what the person's symptoms are. It might be an ultrasound to determine any urinary tract function, electromyography to determine how muscles respond to electrical impulses. There might be nerve conduction studies or even nerve and skin biopsies in some cases. So a comprehensive screening is going to be, it's going to include the things I just discussed. It's also going to include blood pressures, cholesterol, blood sugar screenings. It's going to help the provider kind of rule out what other potential causes there might be so that they can come up with the best treatment plan. So there's 4 types of neuropathy. peripheral neuropathy, which is commonly affects the feet and the legs, fingers, and hands. This is the one that I think most of us often think of when we think about diabetic neuropathy. It usually affects feet and legs first, then hands and arms, and the symptoms are generally worse at night, and they typically do develop symmetrically. So they're going to start to feel it in both feet, both hands, usually around the same time. Some symptoms would be numbness, tingling, pain, cramps, weakness, or extreme sensitivity. There's no uniform sensation that this presents as. It's going to depend on the individual. This also contributes greatly to those foot problems, the foot ulcers, infections, and joint damage like we discussed earlier. Autonomic neuropathy, it has an effect over things like blood pressure, heart rate, sweating, gastric motility. So these people might present with decreased awareness of their low blood sugars, some bowel and bladder changes, difficulty swallowing, any changes to digestion, urination, whether it's new or worsening incontinence or any changes to sexual function should be evaluated. You can start with the PCP, who will then kind of determine next steps if needed, if they need to go to neuro or GI or urology. Any new dizziness or fainting, that should also be evaluated by the provider. Proximal neuropathy, this impacts mostly the thighs, hips, buttocks, and legs. It can also affect the abdomen and chest area. Symptoms usually start on one side of the body, but then can spread to the other. It's often going to be pain in a specific area, weakness or shrinking muscle, and you might see it presented as the person is starting to have difficulty just rising from a chair. Mononeuropathy is going to be damage to just one single nerve. It's usually the face, the torso, the arm, the leg. This might present as difficulty focusing or double vision, weakness in their hand. They might be dropping things. Weakness in lifting the front of the foot. This is when we start to see foot drop, and pain in the front of the thigh. Any new or worsening symptoms, they should be promptly directed to the provider for evaluation to determine the cause. Treatment is going to be very dependent on the specific symptoms and severity. What works for one person may not work for another. So this is when you're going to see, if you have like multiple patients who have diabetic neuropathy, you can see a wide array of treatment plans. It's quite common. You can have 5 people and none of them are going to be treated the same. It's just going to be what works for them. The neuropathy is not curable. It really is just about symptom management and quality of life management as far as the impacts there. So the reminder, any medications, patients should have education on side effects, be completing their follow-ups with the managing provider on schedule. The prescribing providers for neuropathy is typically going to be the person's primary care provider. It might be the endocrinologist or a neurologist. If you have a patient that's being managed by the PCP, they're more than, in most cases, most people can have this condition managed by their primary care. But if they're struggling to find good control or really struggling to have good symptom management, help and support them with getting them steered or referred over to a neurologist for further eval and recommendations if they're kind of struggling there. So the things that we do see, again, a combination of these things, no one's going to have the exact same plan typically. Pain medications, it might be just over-the-counter NSAIDs to prescription pain meds. We don't hardly see opioids used for neuropathy treatment. It's not a mainstay. It's not typically going to be prescribed unless pretty much they've kind of run through the other things and nothing is really working. Anti-seizure medications, these might relieve nerve pain for some folks. Antidepressants, these work by interfering with the chemical process in the brain and the spinal cord that cause a person to feel pain. Topical creams such as capsaicin, lidocaine patches have been found to help some folks. TENS therapy, hypnosis, relaxation, biofeedback, acupuncture. So again, different things for different people. We also want to consider, in all of these treatments, consider the timing of treatments to optimize the effects. So if the symptoms are worse at night, working with the patient to make sure maybe take your medication at a time that the peak effect is going to be reached at the most optimal time for pain relief. Neuropathy can and does increase the risk of injury for some patients, and it can impact overall quality of life. Some additional ways to support and assist the patient's ability to maintain their independence, increase safety, prevent injuries are going to include considerations for home modifications or equipment, physical therapy, and occupational therapy. We want to think about the individual person's neuropathy, how it impacts them, what safety issues it creates, and make sure that we're addressing them and kind of meeting them where they're at. If a person is experiencing emotional or mental health impact, consider referring to behavioral health needs, counseling, support groups. These can also be effective options for helping them learn those relaxation techniques and other exercises to help manage their neuropathic pain. If someone has peripheral neuropathy and lacks the ability to readily sense temperature, consider methods for them to safely test water temps to prevent burns. So things like a thermometer to check before you're washing dishes or getting in the shower or the bath can be helpful. You can also have the person consider adjusting their home water heater to adjust the temperature for their entire house to a level that would prevent a burn despite whichever, if they're in the shower, or the sink or whatnot. If a person has issues with sensory issues in their feet, like balance, coordination, or just general issues with ambulation, consider having a home safety evaluation, education to reduce trips and falls. As with anyone with fall risks, consider a life alert, fall alert system, physical therapy, occupational therapy is needed, or maybe a cane or a walker recommendations. I've had a few neuropathy patients who they're fairly active and they've had a strong desire to stay really active walking outdoors with their spouse or with their friends, but they've kind of struggled just with walking safely on uneven surfaces. So in some cases, something as simple as trekking poles, like those that hikers or backpackers use, have given these types of patients the support that they needed so they can continue doing those activities with the people they love. If autonomic neuropathy results in the individual not able to sense low blood sugars, consider assisting them in obtaining a continuous glucose monitor so that the monitor itself can just be, like it states, monitoring their blood sugars continuously, and it can actually alarm when the blood sugars are low, which can help them better manage those as well. They have difficulty rising from a chair, consider a lift chair, physical therapy for strength, occupational therapy for adapting movements. If they experience foot drop, consider physical therapy for brace recommendations and maybe OT again for adaptive movements. And proper footwear at all times provides that support and protection that can prevent many issues as well. So consider steering to physical therapy to maintain or improve strength and range of motion. While there might be limitations due to neuropathies, improving overall strength, coordination, range of motion, it can improve overall function and also improve the patient's overall mood and outlook as well. PT can also assist with balance training. They can guide on posture and prevention of falls. And then they're also excellent for those considerations for splints or braces. They can be helpful for, compression of mononeuropathies. Again, an example would be a brace for someone who had developed foot drop. Consider steering to occupational therapy, again, for preventing falls. They can do some training to watch for uneven surfaces, foot placement, adjusting habits to adapt and accommodate changes to function. It can be beneficial for assisting in learning, adaptations to maintain independence with many daily activities. And then they can also do some teaching and training on some ergonomic changes. They can learn body changes, body position changes that might reduce their pain and actually increase their mobility. So both physical therapy and occupational therapy can also give additional suggestions and recommendations for adaptive equipment and modifications. So make sure if you have these patients, don't forget PT and OT. They are part of the care team and they have a wealth of knowledge, and they can certainly kind of augment this plan for these patients as well. So some key takeaways here, good management of diabetes and comorbids can help prevent and slow the progression. Like we talked about, identify any barriers to the person's willingness or ability to follow their treatment plan. Again, whether, assist them in making those appointments, ask them if you can call the clinic with them to get them scheduled, so you make sure they're actually scheduling appointments and following through, assist them with whatever barriers there might be with obtaining medications, all of that, as much as we can possibly do to support them following their treatment plan. It's going to support them and prevent a lot of these additional complications that can occur. So identify how their disease process impacts their daily quality of life and assist them in getting them connected with the right provider, the right equipment, or what modifications that they might need to improve their quality of life and management of their disease process. And prompt steerage to the provider for an evaluation. If there's a new symptom, changing symptom, worsening concern, they should not be waiting to get evaluated by their provider. Again, like we stated earlier, just because it's not painful doesn't mean it's not a problem. If they start noticing that they've got redness or any skin areas of concern, anything on their feet, not to wait, have it evaluated. And remember that not everyone experiences the same symptoms, especially related to neuropathy, and their treatment plans will reflect this. I'm stressing this here because as I've been talking to a couple other people here at Blue Cross, we commonly talk to folks who they might go to, Saturday coffee, or they're talking to their sister or someone at church about they both have the same condition, and then they start comparing treatment plans, and then they start to assimilate their treatment plans on their own without actually talking to the provider. Make sure that this is part of the education you're giving them. Your treatment plan is your treatment plan. It might not look like, your cousins or your nephews or, the lady at church or whatever. Make sure that they understand that, and they should be chatting with their provider before they make changes. And just one last time, get them to wear shoes all the time, and make sure that they learn that they can advocate for themselves. It's a very simple thing for them to do, to advocate for themselves, to remove those shoes just at the start of a provider visit, and to make sure that they're checking them daily as well. And then I did just include a couple resources that I have found useful. I know there's a lot of resources out there, and we probably all kind of have our favorites, but I did just want to throw those in here. And then that's kind of all I got for you. If there's any questions.
Awesome. Thank you so much, Becca. This was extremely informative, and I really appreciate your time in putting this all together. And I learned a lot too. I have a lot of family members who this information could benefit from, so this is very helpful. I was monitoring the chat a little bit, so a couple kind of just items that I've seen pop up quite a bit is that everyone really enjoys the presentation, and there's a lot of really good information. We are going to be posting the slides and the recording of this webinar. It's in the chat. Maybe I'll just put the most recent link in the chat just so you guys can all see it. This is where it will live. And Jenna K, correct me if I'm wrong, but I think it might take a couple days, so it might not be immediate there. But the other question, sorry, go ahead, Jenna.
Oh yeah, I was just going to say, yes, it'll take about 3 to 5 business days for it to appear on the website.
Perfect. And then the other question that I've seen pop up a couple of times, actually, Becca, if you can just go down a slide.
I don't know what you mean by down a slide.
Oh, sorry, next. Go to the next one.
The next one? Okay.
My head is scrolling down. That's what that
Okay.
Okay,
gotcha.
So here's the evaluation link at the top here. Once you click on that and fill out the evaluation, once it's done, your certificate of participation should pop up. And therefore you will have your CEUs. And I guess I didn't even realize the link to the recording is also right here to that last piece that we mentioned will be up in just a couple days. So just FYI. And I did see a couple other questions, so I'm gonna go through those quickly. I know we have just a couple minutes. We just scroll. Okay, I see one from, okay, so this is from Julia Ashley. She says, if diabetes is better controlled, does that stop the progression of neuropathy?
It will, this is one of those things where it's going to depend on the person. It will certainly slow the progression. If their blood sugars are not well controlled, their neuropathy symptoms are absolutely only going to get worse. So it's going to depend on the person. I know this is kind of an odd answer. I've seen in some instances where you get them really well controlled, their neuropathy symptoms are never going to reverse. Very commonly, you're not going to see them reverse, but they might not worsen, I guess. And I've seen other folks who they get to the point where their blood sugars and they're pretty well controlled, and their symptoms, the worsening of their symptoms dramatically slows down, but it still does progress. It's going to depend on the person, how long they've been uncontrolled and how much nerve damage has already actually been done. And the other thing too, we have to consider, I know I keep kind of going back to those comorbids, is you can have them really well controlled with their blood sugars and their diabetes, but if they're not continuing to manage the rest of the things, you can and will still see some progression as well.
Great. Okay, thank you. And then one other question, it looks like this from Maureen Greening. She said, can you please review the normal range for blood glucose levels pre and post meals? Thanks.
Yeah, and that's going to be something that, typically we want to see them between 80 and 120 is typically where we like to have them. That's kind of the range that we like to have people's blood sugars in. What you need to keep in mind is different providers for different reasons are going to have kind of goal ranges for your patient. So you want to kind of think about that 80 to 120, but also keep in mind that each individual patient might have their own kind of goal numbers to be at as far as their blood sugar levels. And each person is going to have a different goal A1C as well. There's going to be like the standard where we want to make sure that they're under 6 or under 5.5, but someone's goal A1C might be 7. And for someone that might be high, for someone else that might be exactly where they need to be depending on what their provider's plan is.
Oh, looks like there's one more question from Connie. Is the A1C different for the elderly?
It typically is. It typically is going to be different because with the elderly, we have to be very cautious in tightly controlling their blood sugar levels. So if we get so concerned with getting them, to stay in this 80 to 120 range, sometimes what we can do with their medications or with their insulins is they're more at risk for having those hypoglycemic episodes, which leads to falls, particularly in the elderly. And so those folks, we might not have them as tightly controlled, on a daily blood sugar monitoring schedule. We might be comfortable if they're 130 to 150 or 160. That's going to be a good number for them. And that's going to translate to a higher A1C. So those are going to be the patients we're going to see their goal number for their A1C is going to be higher.
Okay, that makes sense. And then we'll just take one last question. I see that in the chat, it says, this is from Judy Gruber, impact of dialysis on A1C?
That's a really good question, Judy. I do not have personal experience working with dialysis patients, and I feel really bad. I don't particularly know the answer to that. If I gave you one, I would be lying. I can certainly look that up and make sure that gets, that gets to Jenna and can get put as part of the information once it gets posted.
Perfect. Okay, thank you. And it is just 1 o'clock right now. I just want to make one more announcement about the evaluation. So in the chat, they have posted the most up-to-date evaluation link there. Also, Jenna Kornberg had mentioned that once you exit it, you'll automatically see an evaluation link posted, and you can follow it there. And again, that is where you will get the CEU credit. So let's see. I think that is it. And again, thank you so much, Becca. Again, we will post this on the site. And thank you all for your time today.